Welcome to this video on hereditary hemorrhagic telangiectasia. Before we begin, consider the following questions. What is HHT and how is it diagnosed? What are the common ENT and non-ENT manifestations of HHT? What is the underlying pathophysiology of HHT? How should acute nosebleeds be managed in patients with HHT? What are the medical and surgical options that exist for patients with HHT? HHT is a genetic disorder that leads to abnormal blood vessel formation. It is inherited as an autosomal dominant trait and affects 1 in 5,000 people. It's rarely symptomatic in childhood, but 70% of patients will have symptoms by the age of 16 and 90% by 40 years. Epistaxis is the most common symptom, occurring over 90% of patients. It varies in severity and frequency, but can significantly affect quality of life. Nasal telangiectasia are tortuous, dilated superficial vessels, very sensitive to even minor trauma, such as airflow. A lack of elastin fibres mean that the vessels do not vasoconstrict to limit bleeding. HHT is inherited in an autosomal dominant manner due to a heterozygous loss-of-function allele in one of 3 different genes. Those are ENG, ACVRL1, and SMAD4. SMAD4 is associated with juvenile polyposis and a predisposition to gastrointestinal malignancies, and therefore these patients need to be screened for that. These genetic changes lead to an upregulation in vascular endothelial growth factor, causing endothelial proliferation and the characteristic arteriovenous malformations and telangiectasia. The Curacao Criteria is used for the diagnosis of HHT. Number 1 is multiple telangiectasias in typical locations. 2, proven visceral AVMs. 3, spontaneous recurrent epistaxis. 4, a first-degree family member with HHT. If a patient has 3 or 4 criteria, they're said to have definite HHT. 2 criteria gives possible HHT. The main ENT manifestations of HHT are epistaxis and telangiectasia. Epistaxis is the most common and often the first symptom, and the telangiectasia occur on the nasal mucosa, lips, tongue, and oral cavity. The non-ENT manifestations are pulmonary AVMs, and these we screen for as they can lead to hypoxemia, paradoxical embolism, brain abscess, and hemoptysis. Cerebral AVMs, which put you at risk of a hemorrhagic stroke. GI telangiectasia, causing chronic bleeding and anemia. Hepatic AVMs can lead to high-output cardiac failure. HHT is characterized by fragile, abnormally structured blood vessels due to mutations in the TGF-beta signaling pathway, which is crucial for vascular development and maintenance. The hallmark lesions are due to direct connections between the arteries and veins, bypassing the capillary system, leading to fragile vessels prone to bleeding. In order to manage nosebleeds in HHT patients, initial management follows the usual epistaxis management with applying pressure over the soft part of the nose using topical vasoconstrictors such as oxymetazoline or phenylephrine and topical hemostatic agents such as tranexamic acid. If simple measures have not controlled the epistaxis, it's possible to go ahead with cauterization, although many of these patients will have had multiple attempts at cautery, and it is more difficult to stop the bleeding in this patient cohort. Can also try nasal packing. In HHT patients, we prefer to use absorbable packing materials as opposed to the rigid ones that may traumatize the nasal lining. In patients with HHT, we record the intensity, frequency, and severity of their nosebleeds using a nosebleed grading scale. Medical options for treatment in patients with HHT include nasal emollients such as Vaseline, rotating antibiotic nasal creams, saline drops or spray, hormonal therapy, anti-estrogens such as tamoxifen, antifibrinolytic agents such as tranexamic acid, bevacizumab, an anti-VEGF therapy which has been shown to reduce epistaxis but is currently not NICE approved in the UK. Also, these patients require iron supplementations to manage their chronic anemia. Surgical treatment includes laser therapy to treat the nasal telangiectasia, a septodermoplasty to replace the nasal mucosa with a skin graft, or a Young's procedure to close the nasal cavity in patients with severe epistaxis who may be transfusion dependent. The management of HHT often requires coordination with multiple specialties including ENT, respiratory, gastroenterology, haematology and interventional radiology. Regular follow-ups are essential to monitor for complications and to manage chronic symptoms effectively. There are a wide range of treatment options for epistaxis and HHT. The treatment depends on the frequency and severity of bleeding, and different patients will respond in different ways to the treatments. It's not one fix fits all.
I hope you found this video to be useful. Please consider subscribing and let us know what you'd like us to cover next.